framework for counseling patients immediately after a myocardial infarction, or what we usually just call a heart attack. If you've ever wondered exactly how doctors are trained to walk a patient and their family through literally one of the most terrifying moments of their lives, well, you are absolutely in the right place. We're going to look at the exact architecture of this consultation straight from standard clinical guidelines, tracing how a physician moves a patient from that initial bedside trauma all the way through to long-term home recovery. So here's our chronological playbook. We're going to start with a bedside empathy loop, then move into explaining the plumbing problem, the core medication shield, the 5-minute emergency rule, the bridge to normalcy, and finally, healing the hidden scars. Let's get right into it. Phase 1, the bedside empathy loop. Right at the bedside during a patient's absolute most vulnerable moments, often just after major hospital procedures have finished up, doctors are actually trained to use scripted, deeply human statements. They might say something like, "I know the last few days have been incredibly scary and overwhelming for you and your family." The goal here is simple, but it is profound. You have to validate the trauma. This active validation keeps the physician from accidentally talking way over the patient's head. Think about it. If a patient is frozen in fear, there's no way they're going to absorb complex medical instructions, right? That trust just has to come first. Dr. Asafullah refers to this brilliant strategy as the empathy loop. It's the foundational tool for establishing that crucial trust before you even think about diving into the medical plan. You don't just stand there and lecture the patient. First, you ask to assess their baseline knowledge. Something like, "Can you tell me what you understand so far about what happened to your heart?" Then you tell them the necessary medical information. And finally, you ask again to verify that they actually comprehended it. It creates this continuous, stabilizing loop of check-ins. Moving on to phase 2, explaining the plumbing problem. Once that empathy is established and the trust is there, the doctor transitions into demystifying exactly what just happened. And they do this by translating terrifying, jargon-heavy medical realities into a really patient-friendly plumbing analogy. Instead of throwing around terms like plaque rupture and myocardial infarctions, they tell the patient to think of the blood vessels supplying their heart kind of like pipes. Over time, plaque builds up on the walls of these pipes. Recently, a piece of that block ruptured, which caused a clot to form. This completely blocked the pipe, essentially starving a part of the heart muscle of oxygen, and that starvation is exactly what caused their severe chest pain. To explain the coronary intervention, the doctor explains that the cardiology team went in with a tiny wire and placed a stent. They'll describe this stent as a tiny metal scaffolding that basically pushes the plaque aside and props the artery open to restore that crucial blood flow. So the heart is getting oxygen again, but the muscle itself, it still needs time to heal. This establishes the ultimate goal for the days ahead. Now that the artery is open, goal number 1 is to keep it open, and achieving that requires a very specific medical plan. Phase 3, the core medication shield. Securing adherence to life-saving medical therapies is vital, which means the standard subcore regimen, that's statins, antiplatelets, ACE inhibitors or ARBs, and beta blockers, needs to be broken down into simple, memorable metaphors. Statins reduce inflammation, so the doctor tells the patient they stabilize the block in the arteries so it doesn't rupture again. Antiplatelets prevent stent thrombosis, so they are perfectly described as making the blood slippery and thin, ensuring a clot cannot form on that brand new metal stent. ACE inhibitors or ARBs prevent pathological remodeling, which just translates to preventing the heart muscle from scarring and changing shape. And finally, beta blockers reduce chronotropic demand. In plain terms, they act as shield for the heart, slowing the heart rate down and reducing its daily workload. The doctor will even suggest the patient keep these medications right by their side, using the catch covers to remember exactly what each one does. Now, during this phase, the doctor also has to stress some pretty dire warnings to ensure compliance. They specifically remind the patient that they must absolutely never stop taking their antiplatelets without directly talking to a cardiologist first. These medications might be used for up to 12 months, and halting them prematurely, it can be incredibly dangerous for that new stent. Phase 4, the 5-minute emergency rule. Taking daily pills is one thing, but knowing exactly what to do when things go wrong at home is just as critical. This brings us to a strict, high-stakes decision tree for using nitroglycerin. It gives patients a highly precise protocol if they experience that familiar chest heaviness or shortness of breath once they're home. Step 1, stop all activities and sit down immediately. Give a rapid cough. Step 2, take 1 nitroglycerin tablet sublingually, right under the tongue. Step 3, wait exactly 5 minutes. Step 4, if the pain is still there, do not wait any longer. Call local emergency services like 911 or 112. And finally, step 5, while waiting for the ambulance, a second tablet may be taken. If the pain vanishes after the first tablet, they can rest and just resume their other medications on schedule. And there's a rule here that literally cannot be overstated. The doctor emphatically warns the patient, never, ever drive to the hospital by yourself during an emergency. It is way too dangerous. Accidents can easily happen if you suddenly lose consciousness, and overspeeding out of sheer panic can quite literally kill you or someone else. You always call the ambulance. Phase 5, the bridge to normalcy. Now we shift focus to the safest way to rebuild physical strength and manage lifestyle. Doctors use what's called the 5 A's framework: ask, advise, assess, assist, and arrange to build a safe bridge back to normal life. They'll prescribe an outpatient cardiac rehab program where exercise physiotherapists and nurses monitor the heart while the patient safely rebuilds endurance. They also heavily target lifestyle interventions, highlighting a massive statistic. Simply quitting smoking cuts the risk of a second heart attack by 50%, half. They might even prescribe patches or gums if the patient is struggling to quit. The dietary advice usually includes adopting a DASH or Mediterranean diet. We're talking lean meats, olive oils, fruits, veggies, while strictly avoiding fried, processed, or packaged foods that are loaded with added salt. Finally, they aim for a healthy BMI and advise no or only very moderate alcohol intake. Understandably, patients always want to know when they can get their life back. This highly practical recovery dashboard maps out exactly when a patient can expect to return to their normal daily routines. Intimacy can generally resume in 1 to 2 weeks, and that's typically gauged by whether the patient can briskly walk up a flight of stairs without severe shortness of breath. Driving usually takes 1 to 4 weeks, though heavy truck drivers have to consult their specific local transport rules. And returning to work, that can take anywhere from 2 to 6 weeks, which heavily depends on the actual physical demands of their specific job. However, when discussing that return to intimacy, a critical and stark warning has to be issued. The doctor must advise the patient never to mix their nitroglycerin with performance drugs like sildenafil or Viagra. Taking these together causes a severe and potentially fatal hypotensive effect, which means a massive, highly dangerous drop in blood pressure. Phase 6, healing the hidden scars. Dr. Asifullah's guide concludes by addressing something that is, honestly, way too often overlooked: the unseen psychological toll of surviving a massive health crisis. This isn't just about feeling a bit down. Mental health overlap is a core clinical metric that requires active screening. There is a staggering 20% prevalence of post-MI depression. That's 1 in 5 patients. And here's exactly why doctors care so deeply about this. Depression actively worsens cardiovascular outcomes. Simply put, fixing the plumbing isn't enough if the patient loses the will to recover. Using those exact same empathetic scripts from the beginning, the doctor normalizes these really complex feelings. They tell the patient that being reminded of our own mortality naturally brings up anxiety and anger. They'll actively screen for specific hidden signs, asking the patient to report if they find themselves unable to sleep, having sudden crying spells, or just losing interest in things they used to love. By validating that this is a completely normal reaction to severe trauma, they ensure the patient gets the necessary psychosocial support they need to truly heal. All of these phases come together in a final mandatory post-MI ward checklist. The physician has to ensure that empathy was established, confusing jargon was avoided, drug compliance for the core regimen was heavily stressed, emergency rules are completely understood, rehab is referred, return to life timelines are crystal clear, and depression is addressed. Only when this checklist is fully completed is the patient safely discharged to home care. Which leaves us with a pretty profound final question to